Assalamu alaikum, everybody, and welcome to our nuclear medicine and molecular imaging session. We're here after lunch, so we've got some exciting talks to keep you all awake and fully engrossed. We've got specialists from around the world. What I'm going to do is I'm going to introduce our moderators, and then they'll take over the session. So we have Dr. Ahmed Qureshi, senior nuclear physician, as we all know, ex-DG of the Atomic Energy and currently working at Shaukat Khanum, Lahore. Then we have Dr. Hajra. Dr. Hajra Ilyas is dual trained in radiology as well as nuclear medicine. She relocated from England and is with us at Shaukat Khanum, Peshawar. So I will now invite you both to please introduce our speakers and initiate our session, please.
Assalamu alaikum. Thank you for that, Dr. Amna. I'm going to briefly introduce Dr. Athar Haroon, and I think he'll add a bit more to that introduction. He is dual trained radiologist and nuclear medicine physician, and he's worked 10 years in the UK and clinical lead as well in one of the busiest centers in London. He's now in the last few years also working in Qatar, and we're very lucky to have him here with us today and are grateful that he found the time to join us in person this afternoon. Thank you. And he's going to talk first about, the topic of his first talk is multiparametric PSMA PET of the prostate, lesions, pearls, and pitfalls.
Thank you very much. 30 years, 6 months wait to come and stand. Bit of an emotional moment, to be honest. It's been a long journey. Intezar tha, that's what I would actually say. I graduated from Army Medical College. After internship, went to England, did MRCS, did anatomy teaching at the University of Leicester, did my radiology fellowship, did the CCT for radiology. Following that, nuclear medicine fellowship, completed the training. There's another started a small job in it's a nuclear medicine radiology job. And then I went for my PhD, which was related to nuclear medicine and molecular imaging. Then I worked at St. Bart's Hospital, as Dr. Hajra said. So I was working there as a consultant radiologist, and later on, I was appointed as a clinical lead for nuclear medicine over there. And from there on, I moved to Qatar. I'm going to talk about multiparametric PSMA PET of the prostate, lesion, pearls, and pitfalls. This is a new concept, something very new, very innovative. There is not much literature you will find on this topic at present, as we speak at this moment. So these are my disclosures. I'm a reviewer of applications for Health Research Authority UK. I was part of the PET-MR advisory board for the Siemens. I hold grants with the Bart's charity, and I was part of a co-investigator for a November prostate grant, some trial reporting. As a courtesy, we all display our disclosures. Bart's completed 900 years this year. So it's one of the oldest institute of UK, first hospital which was built. The place gives surprises. This is how the building actually looks like from outside, and this is how it looks like from inside. And if I have the laser pointer, so our department, you go down from here, is the nuclear medicine department. And I put down sign for the nuclear medicine, and this is how you move into the corridors and stuff. This is the largest cardio-oncology center of Europe. So it's like all cardiac, so all cardiac services have been brought in together, all the oncologists have been brought in together, so there are very interesting things. So this is actually a result of all of those, when you are talking to them and what's actually going on. So I have the least level of knowledge at this topic. This was the topic of my PhD. That is what I was told when I was given my diploma. I am the co-author of the prostate cancer guidelines for the UK, which is implemented all over and practiced England, Scotland, Northern Ireland, and all of those places and stuff. I need not to give an introduction about the PET-CT. All it is, you rotate the particles and you hit it with another particle to generate energy. The PET scanner It creates some beautiful images with the help of the crystals by zooming up the signal intensity. What's the news now? So all of you should know that there are total body scanners in place now, okay? 1 minute, 11 seconds is the output. Stefano Fanti from Italy and Professor Hoffman, they have told that they are doing 83 to 85 cases in a day. That's a slow day for them. And within 2 years, it will be faster than the X-ray, where nuclear medicine is actually heading to. Welcome to that. Dynamic multiparametric imaging. Gone are the days when there was pixelated image. You will see blood going through. I'll stop over here. I wish I had some bottles over here and I could hit it with a metal. And I could hit it with different frequencies so that all of you could actually hear this sound. Now, why I'm actually telling you, think what the oncologist is doing when he's giving medicines. For example, there is one medicine you have given and it produces this sound, slow, tuck, 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 tuck. There is another one which does this, right? That's all this talk is about. Faster binding, faster hitting of the cells will kill the cancer. Slow one is not going to work. This was the idea behind all this protocol and every single thing what you're going to listen. So this is the mission statement that when we started, that we decided we'll come out with a protocol that will be the first one in the UK. That will be a new paradigm shift in molecular imaging of prostate. And that will be equally, not less, but equally good than multiparametric MRI. Because I have a radiology background, so is the many people. You know that the MRI is a very well-established area in prostate cancer imaging, radiation-free. Call it a disadvantage that nuclear medicine gets. Radiation, you know, the patients, they get scared. Wish we had some fancy word to explain to the patients. And we could use the word like molecular imaging. Now everybody will be coming, you know, I want to have molecular imaging and stuff. Now, you all, whoever are reporting PET-CT, should be familiar with these artifacts. Look at the extrated activity in the bladder, which is going all over the places. If somebody is reporting PET-CT and doing PET-CT and hasn't seen this, this will be a surprise. And look how much of the extrated activity is there in the urinary bladder. That's the problem. That the clinician is expecting us. Look, I have a beautiful MRI which can tell me everything. You tell me where is the recurrence, where is the cancer, and we struggle with this issue of extrated activity of the urinary bladder. And it kills the beauty of our exam. We help them with the staging. This is another thing we encounter. Look at how the images look like. Artifacts flooded with it. An expensive test. PET-CT is not cheap. It's an expensive test. You pay the thing from your pocket, and I show you, look, I write down, there's an artifact. I can't tell. Put yourself in the place of the patients and the relatives. So we gave them this much money, and that's what the report they have issued. Okay? Look at the quality of the images. Okay? All flooded with artifacts. Extrated activity in the bladder, and you can't see what is actually going on. So these are the dates, 17th June to 7th of October, where all this journey actually happened. Now, this is what I'm telling you is actually the real story, what actually happened. Our department bought a mobile PET scanner. The manager was very happy, and he parked it in the car park. Very excited to show the management what a fantastic thing. We can now start scanning. It's cheaper and it's very good. Forgot that there had to be an environmental agency inspections, and our physics colleagues have to be respected for radiation protection point of view. Nuclear medicine, we work in the form of a team. We don't work without physics. We don't work without pharmacists. We don't work without our support staff, our technologists, and all of that. Environmental agency and the physics people, these patients were asked that they were injected and they were asked to empty the bladder. So they will come all the way from that auditorium, double the distance. They will come back and they will pass urine and they will go back. And they said, you have injected the patient with radioisotope. Can you guarantee where is all the dribbling taking place? Now, if they had picked up collimators and if they started tracking activity, that would have been a serious warning. It did not happen, but they politely said, get ready for the service shutdown. You're not going to have the service now. And my head of department asked me, what do we do? Though they'll ask us to close the service, what do we do? So we were doing cardiac PET. We were doing rubidium PET over there, in which we were injecting the tracer imaging. And I was a fellow at UCLH where I was doing my fellowship over there. And I asked, look, let's combine the protocols together. Let's put the rubidium protocol into the prostate and see how the blood flow comes up and stuff. There were other literature on the dynamic imaging, but I asked them that we need to make it look beautiful. We need to make it look fascinating, that whoever sees the images, they look good. So this post-micturition image was one of the trial that they tried, that you ask the patient to empty the bladder, but there was logistical issue related to our site-specific thing. And then after that, we came up with this protocol. Now, what we did, I asked them, don't ask the patient to empty the bladder. Don't do that, okay? Put the patient on the scanner and you inject the patient then and there. But I want the camera to start 8 to 10 seconds before the injection starts, just like a MAC3 renogram. But the reconstructions will be different. And I showed you the dates on the previous slide where the email exchange was. There was June to October. And June to October, the number of sequences which I have tried to study to come up with the 3D image, it just drove me crazy. All those physics equation, I don't want to go. Just believe E is equal to MC squared, right? Just for the time being, okay? I was criticized that I'm adding 6 minutes of imaging time. Lists are busy. In one day, you are missing out. You scan 4 patients, you are delaying us. You are costly. You are doing this. And I told them, no, this is not how it will work. You inject the patient, take him out, bring next FDG in there. Finish off FDG, bring that patient back in there. And rather than one, we'll be scanning 4 patients because you'll replicate the same protocol in 2 scanners. So the output actually doubled. So that was another counterattack that it's not going to stop and we have to go forward. So at the time, we have done more than 300 cases so far, but for the sake of presentation, and I was asked by the radiation experts and all the stuff that you said that there won't be a problem, that the patient will not have X-rated activity. Tell us, and you analyze, and you tell us what the results are. So we analyzed 70 patients, which had low-dose CT and full protocol of multiparametric and all the stuff. And we assessed whether the PSMA receptor binding is taking place, means there is an avid lesion there. What is the happening with the X-rated activity? And all they wanted to hear was how much of the X-rated activity is there. You pick it up, your service is again out, okay? Now, we obtained the data and we collected SUV variables and every single thing. Pleasant surprise, 99% success. We were fascinated. There was 1 patient only, 3 in fact. What happened? That the technologist panicked because the injection got delayed and he started the camera. There was a bit of a panic. And there was a trickle of activity in the urinary bladder. Now, 99% is a fantastic result when you want to change an intervention. If you want to bring in a quality improvement project, 10%, 12% is a very good change. 99% was fascinating. And that was the first time we were able to see ureteric jet, that how as the excreted activity enters the urinary bladder. This is how the image looked like. Now have a look at the image over there. This is how the prostate image looks like. Okay, how many of you have seen images like this? And these are all the blood vessels which are shining up, which are physics-fully helped to do the reconstruction to make it look time of flight. Not a drop of urine there, not a single artifact from any of the metal thing there. Any single lesion you see is positive. Any node you see is positive. You do not get distracted by the excreted activity in the ureter either. So you clearly say anything what you're seeing is a lesion there. And in the pelvis, you see the tracer just in the blood vessels, which is a checkpoint, and you see nice blood vessels shining out, a negative scan. Okay? Let's go back to the next one now. This patient, you see the lesion over there, minimal activity, and you see the positive scan over there. Okay? No lymph node, you can see the metastatic spread, you can see the nodes over there. So all that problem of artifacts and everything is gone. Not a single patient had the comet tail artifact. So the comet tail artifact gone, movement artifact gone, excreted activity problem gone, problem with the lymph node identification close to the ureter, that all disappeared. Now, have a look at this patient now. This is a scan post-surgery, post-radical prostatectomy. We are asked to tell us about the recurrence in the prostatectomy bed. Look at how nicely the bladder has given neutral contrast. The same thing we used to ask them to empty. We are doing the opposite of it. We are putting rubidium protocol in there. we're getting the blood vessels, and we are able to see exact margins, what is actually happening around them. Okay, no artifact caused by the excreted activity in the urinary bladder. So now at the time of this thing, we hadn't done the validation. The true validation is that you have a gold standard against which you assess what you are actually saying. Just for your knowledge of all of you. If you want to win the trust of the clinicians, you have to tell where you are making the mistake. Not that how good we are. If you're a radiologist, you pick up paper radiology, you will see the highest sensitivities and specificity. You open JNM, nuclear medicine paper, highest sensitivity. You remember choline PET when it was introduced, they started quoting number of 98, 99%. Now everybody hates choline. Okay, this is all. So we have published a paper in AJR where we compared our data of choline with MR template guided biopsies. And we segregated true positives, true negatives, false positive, and false negatives. And we displayed them. We are going to apply the same logic in our data, but not many patients had template biases for these cases and stuff. Now, this is another case, another example. This is an image of a routine whole body PET-CT. The consultant was saying that this is a non-dependent part. There is an increased activity there. There must be a bladder lesion there. Okay. You show it to anyone, you adjust the window, you will see there is a lesion there, and it's a non-dependent part. You see that it's not at the base. Multiparameter PET, no lesion there. You see a full bladder wall with no artifact, nothing. That was an artifact. The density difference of the tracer rising up to the urinary bladder and looking like that. This is the multiparametric MRI. Those who are not in radiology, it's just to demonstrate them that there is restricted diffusion, a lesion on the left-hand side. This is the area where I'm displaying the abnormality. Another level higher up to cover the seminal vesicles, that if there is any lesion there. So just to show you that this is where the lesion is abnormal, which is prostate cancer. And this is how the image multiparametric looks like. Okay, so you just simply no artifact from the bladder, nodes and every single thing, and you see it shining. Another case, perineal recurrence. Very, very difficult. If patient has full bladder, you will find it very difficult. All you have to see it, make sure that you have some activity in the blood vessels, and any positive focus in the perineum will be a recurrence. Simple, very, very, very simple. And on the MIP image, this is the another example. In routine reporting, we will struggle. We will call it, there is excreted activity, and we will say, no, this is nothing. In this protocol, you don't do that. Anything positive is abnormal. Simple, binary, yes or no, simple answer. Anything that shines. This is another case. I would actually say this is the second most beautiful slide of this presentation, because look at this, how many of us can actually see there is a tumor sitting there, right? Now have a look at it. Empty bladder, blood vessels shining up, no ureteric activity, clips over there, tumor sitting there. Yes, no, right? Straightforward, full stop. Right, so there have been some, this is not my idea, just to be clear. There are people who have published in dynamic imaging. All I have done is try to combine different techniques together, and they have also shown that they are able to pick up more lesions. So I'll not bore you with the references, those are there. You can read around the literature that what is actually happening about those. I want to talk about these graphs. I think we should, in nuclear medicine, we need to make it more fascinating, and we need to think what will be the magic numbers apart from the SUVs which we are going to give to the clinicians. Look, in MRI, they are giving grading. There is PIRADS grade 4, 5, and clinicians, they understand it. We need to come up with a scoring system. We need to come up with a grading system. So as part of the PhD work, we were doing some kinetic modeling and stuff. We can actually tell how fast it is binding. That's the only news I can tell right now. Some of the data is protected because of the because it's not been released yet and stuff. But I think in next 2 to 3 years, because the total body PET scanners are coming in, and there is a lot of, all of them are replicating actually this protocol, you will see nuclear medicine colleagues joining hands together to come out with a classification system. And Shaukat Khanum is also welcome to be part of this. We can join the party and we can come up with a classification system of grading system 1, 2, 3, 4, 5, something very easy, 1 being not cancer, 5 being a cancer, just to make it simple and easy, because this is where the radiology grading system is taking advantage, right? So there are plenty of numbers which can come out. I've shown this image for a reason. So my work is different than the traditional work which has been published, because in most of the papers, what you will see, the dynamic images are displayed like this. Whatever your software and things are, actually the time gap between the 19th of June to the 7th of October was spent trying to make it beautiful. That how do I avoid this kind of a thing for a clinic? Clinicians, they want simple images. So this is all that effort is about. Look at it, how beautiful the images come out. Imagine reporting prostate, PSMA PET CT, a dot shining over there, a dot shining there is a lymph node, and you say there is a lesion in the left lobe, node over there. There you actually go. Not a single. So we have done another thing. We realized that Siemens have got some metal artifact reduction sequence as well, which was, I wish I knew. I didn't know it was there, by the way. I didn't know that. It was a big manual which they had sent me, and I was losing sleep that, how much of a relevant thing will come out. But that's the summary of all the beautiful images which have actually come out with some more examples of the curves, and this thing is produced. Now, you have a look at it, that this is the main problem which I was saying, that once the bladder fills up, there is a drop in the signal intensity in the region around it. That's because of the way the PET CT work. It drifts towards the high energy side. That's intrinsic. That's the nature of the way the scanner is. Now, when we do the multiparametric, we don't see the activity, you don't see the dropout. So you see the look at this white area. You will see that that white area is actually reduced. So you're not getting a dropout of the PET signal intensity in that area, and keeping it very, very simple, right? So this is the protocol for Shaukat Khanum. If I have to put a special request to the InHealth to support and the fund and share the protocol, we'll be very happy to do that. It's this much of a reputation with them because their business has rocketed and they are very, very happy. The team, Kelly, who worked with me to set up the protocol, our divisional directors, Ralph, Barbara. She's the one who supported the maximum. She was our head of department. And I've shown you this image because of this project. In UK, the health services are categorized and they are selected for awards. We went to the shortlisting stage. We went up to the top 5. We did not win the award, but they were actually very happy. They were saying that if an innovative project, if an innovative thing is making a difference and it's being heard at national level, and we have been invited. I mean, I was not there. They were all enjoying the pictures and stuff, and I was teasing them off. That's not very good. A good book, a novel by Eric Siegel. This is a love story of 2 medical students who went through Harvard Medical School. And there is a lecture by a very experienced professor, their first lecture. And they said, there are only 26 facts in medicine. Rest all is guesswork. And they remembered it throughout their career. So, summary, this is the traditional PET CT, this is the MRI, and this is us. Okay? So I leave you to decide how glamorous and how beautiful and how fascinating you want nuclear medicine to be. And I'm sure, inshallah, we will make more improvements. We'll look at much better with scoring system and every single thing. My memories, the time I spend and come and see, I was telling Dr. Amna that I come and talk to the patients and that charge my battery when I hear good stories. British Nuclear Medicine Society awarded first research prize for the prostate cancer imaging. And I had this check with me for quite some time. And I'll give that once, the first time I'll get the chance to come to Shaukat Khanum, then I will give it to. I'll give the money and then donate that. So I've already met your guy, he's in there. This check is very important for me. It's very prestigious for me. It's not the amount. 100 is nothing. £100 is nothing. But I think the memories and the time spent, that is actually what matters. There's an RSNA prize as well, but this is the one related to the prostate, which I'll restrict over there. Thank you very much. Thank you.
Thank you so much for a lovely talk. We'll just do the questions at the end together, if
Yep.
that's okay. Thank you.
Our next speaker is Dr. Saima Muzdahir. She is a graduate of Mr. Medical College, and she did her fellowship FCPS from Shaukat Khanum. And that's a great honor for us. He's here after doing her diplomat American board. He has done his PET CT fellowship from America. She's also a fellow of Royal College of Edinburgh. She is currently working as associate professor of radiology and is a lead theranostics at the Emory Department of Nuclear Medicine, Georgia. Among other things, she is also board director of SNMMI, and she is also board director of SNMI. Indeed, it's an honor for us, for Pakistan, that one of the graduates of Pakistan are doing such great things abroad. Her specialty is about radioligands therapies and breast cancer related imaging. And she is here to give us insight about PET MRI in clinical practice, principles, strengths, and weaknesses. Dr. Saima, please.
Thank you very much, Dr. Ahmed, for your kind introduction. Dr. Ahmed has already given a detailed introduction, so without further ado, we'll dive into the subject. So I'm going to talk about PET-MR, its clinical practice, principles, strengths, and weaknesses. I would rather say it's not a weakness, the challenges that we encounter each day. So regarding disclosures, I don't have any disclosures. PET-MR, I promise it's not going to be that scary. All right. So a brief overview of what we are going to cover today. What exactly is in a PET-MR? What are the major clinical applications? What are the different PET-MR protocols? The different PET-MR protocols, I'll briefly touch upon that. What are the different sequences and nomenclature that we use? Reading interpretation, what to look for, and this is more geared towards NUCMED people who don't have that much of a radiology MR background. Then we'll review some clinical cases, and then last but not the least, we'll touch about some challenges related to PET-MR. So what exactly is in a PET-MR? It's a high-end PET with a 3T magnet in the same integrated gantry. So all the MR sequence of a standard diagnostic MR are incorporated in that. So unlike sequential PET-CT, PET-MR is simultaneous. So that means it has the advantage of a single imaging exam instead of two separate exams. It's better co-localized and registered compared to PET-CT and or PET and MR done separately, as exams acquired are in the same patient position. So it improves the confidence and interpretation. Of course, better patient compliance since it's a single exam. And if we look at the cost, because in US, everything is geared towards cost, it's a socialist society. So the total exam price less than PET-CT and diagnostic MR separately. And we have been doing PET-MRs at Emory since November of 2021. And on the average, we do 4 to 5 PETs per week, PET-MR, sorry. So why and when do we need PET-MR? Cancers that require MR for local staging and PET for overall systemic staging, such as rectal cancers, prostate, gynecologic malignancies, PET-MR comes in very handy. Then liver lesions, whether it's HCC or metastases, and these could be better characterized with both modalities. And then cancers which are difficult to accurately estimate response, particularly after radiation therapy, where you get non-specific changes on the MR, PET offers advantage, and then you have the MR with it. What other? Seizure localization, where imaging can be completed in a single session, and multiple myeloma as well. So if you look at the major clinical applications in PET-MR, you see that oncologic imaging forms the major bulk of PET-MR clinical application. And among the oncologic imaging, you see that the main bulk is prostate cancer imaging, then comes breast, brain imaging, followed by neuroendocrine tumors, and so on and so forth. So what's the general acquisition protocol in a PET MR? So there are two parts to it. There's a whole body exam, which is almost 6 to 8 bed positions, 150 seconds per bed, except for copper, where we require a little longer. And then there is a regional single bed position, which is 18 to 20 minutes. And the total scan time is around 40 to 45 minutes, maximum up to 50, and the minimum is 40. And neuro protocols are even shorter, 20 to 25 minutes. So this is how FDG whole body PET MR looks like. So this is acquired, and then we do the regional PET MR, which is, we also call it as super PET at Emory, and it's a more detailed data acquisition because it takes longer to do the regional PET MR versus the whole body PET MR. So how do we do it? Let's suppose it's for HCC. We do the whole body PET MR first. Then we do the regional liver PET MR after the whole body. And what sequences do we acquire for the whole body? We do the whole body T2, T1, and pre and post. This is how it looks like, 2.5 minutes per bed position for 5 to 6 bed positions. So this is the whole body, followed by the liver, which is the regional, along with all the sequences that a diagnostic MR requires, followed by the whole body T1 post. For pelvic lesions, which are where you don't have the concern for any liver lesion, at Emory, we usually acquire the regional PET MR first, and that's strategic because if the patient does not cooperate for the whole body, you get the specific regional PET MR, the whole body PET MR. And again, for this, now what sequences you would get for the whole body? You get the whole body T2 and T1 post. You don't get the T1 pre because you already are acquiring the whole body after the regional. So the contrast is already on board. And this is how it's acquired. You do the regional pelvic MR first with all the diagnostic MR sequences, followed by the T1 post, whole body. And this is again 5 to 6 bed positions. And then we also do a lot of PET dotatate imaging. Again, for PET dotatate, we do the whole body first. And here we acquire a little longer, 3.5 versus 2.5 minutes for the FDG bed. And then followed by the dedicated liver MR protocol, and then the whole body T1 post. In prostate MR, all the prostate MR diagnostic sequences are acquired, including the dynamic post-contrast images. And then, in prostate, what's different is when we started doing it, we were using Exumin, which is F18 fluciclovine, and that was the agent which was developed at Emory University. And the beauty of Exumin was that it was very good with very minimal bladder activity. So it was a good agent to detect local recurrence at the vesicourethral junction. So in that, the imaging acquisition was performed about 3.5 minutes after injecting Exumin. So you would do the prostate MR protocol first, followed by the whole body PET MR imaging. And same holds true for the PSMA PET. Again, you inject, you wait 60 to 80 minutes, and you do the regional PET MR, which is the prostate with all the sequences, which takes about 20 to 25 minutes, then followed by the whole body T1. For brain, it's faster. It's a single bed position, approximately 25 minutes, including seizure protocol, along with list more data for PET. So what are the basic MR sequences? These are just T1 and T2 weighted images with different nomenclatures. So easy to remember. T1, one tissue type is bright, which is fat. And T2 is 2 tissue types are bright, fat, and water. This is the very basic to remember. And if you look at the MR conceptuality, grossly think of T1 as the anatomy type sequence and T2 as the tissue characterization type. So this gets very complicated and nuanced as you get deeper into it, but that's just a basic outline. This is what the T1 and T2 sequences basically are. So this is a T1 fat suppressed image where the water is not bright. And then this is T2 single shot where you see the CSF bright and the fat is bright too. So the main MR whole body sequences that you would be looking on a PET MR, you have axial T2, you have T1 pre and post images. From order to report, like when we do PET MR, patients are scheduled. All exams are protocoled by an MD, and then the MR techs actually perform their standard MR safety assessment and contact patients to make sure that they are able to go through the exam. How do we read those PET MR scans at Emory? So there are 2 accession numbers assigned to each PET MR. And so there's a whole body MR images to PET accession, and then there is a regional MR to MR accession number. So this is how it's displayed. So the nuclear medicine division reads the PET MR whole body, and we do look at the regional PET MR as well. And then our body division colleagues read the diagnostic prostate MR images. What are the MR sequences to look for when we are reading those PET MRs? So all sequences are important, right, in the whole body, but I would recommend for the regional T1 post-venous gives you the best yield, although it's always looked to other sequences as well. And what's the best bang for your buck? As I said, T1 post is the most useful, followed by whole body T2 or followed by whole body T1. So we use MIM software to view all our PET MRs or PET CTs. So this is how that's a lot of data that's pushed to all the MIM servers. As you can see, what's highlighted is there's both whole body and regional images. And of course, the whole body images have more images, so it's self-explanatory. So we have T1 post, PET attenuated corrected, non-attenuated corrected data. Then you can see whole body T2 and the pre-water. And then you have the regional images, which are again respiratory gated, so avoid to minimize any motion artifact that may have happened. And then you have all the regional MR sequences as well. So whole body PET versus regional. Why do we do those regional PET MR images when we already are requiring the whole body? So look at this. This is a whole body PET MR, and you can faintly see a lesion in the dome of the liver, which is pointed by this pink arrow. And it's, but when we did the regional PET MR, see how much, the resolution of the scan, the regional PET MR is much higher than the whole body, which is what it should be, because the whole body is 2.5 to 3.5 minutes per bed position versus a single bed of PET MR of 20 minutes. Of course, more data acquisition, better resolution. So let's look at the few cases here. So newly diagnosed unfavorable intermediate risk prostate cancer, patient underwent PSMA PET. And here you can see that focal radio uptake in the peripheral zone of the prostate, corresponding to primary prostate malignancy, no nodal or distant metastasis here. Case 2, this is a prostate cancer status post treatment by laser ablation in the past, now presenting with biochemical recurrence, rising PSA levels. PSMA PET was performed, and you can see this area of enhancement in the right prostate lobe. This is the dynamic contrast enhanced image showing the enhancement. And then there was nodal disease in the right pelvic side wall. This is the nodal disease. Why am I showing you this case? Because it gets really tricky in the prostate cancer post-radiation when you see a lot of changes, and then your dynamic contrast enhanced and ADC images are not useful in those cases. The best images which are helpful are the dynamic post-contrast images, where you can see this dynamic post-contrast show this area of enhancement, and then PET also confirmed that this area has uptake and concerning for malignancy. So PSMA is sensitive for uptake in treated prostate, where specificity is relatively low, and this is where MR helps. So the two modalities in tandem for better patient management. Case number 3, this is a nice case of cholangiocarcinoma. Post-yttrium 90 radioembolization, you can see multiple lesions which appear photopenic. These are the treated liver metastases, non-viable tumor. But then you see all these areas of increased uptake peripherally in some of the treated lesions concerning for recurrence. where MR alone would not have been very helpful. And then the new tumors were also identified. Case number 4, BRCA1 recurrent high-grade serous ovarian carcinoma. MR was performed in October 2022. You can see a nodule at the vaginal stump with post-contrast enhancement. So this was disease. Patient underwent radiation therapy, and then you can see the lesion getting smaller, but this still shows some enhancement. So this was concerning whether this is viable tumor or not. And you can see that PET-MR helped because this is baseline, and then follow-up doesn't show marked uptake. So that was a new post-radiation treatment changes. Another case, 55-year-old with pancreatic cancer, referred for PET-MR during consideration for radiation therapy to liver to exclude extrahepatic disease. And then here you see very unsuspected recurrent pancreatic cancer at the resection margin, which was not very hard to see on the MR images alone. So change the patient management here. Case number 6, locally advanced pancreatic cancer. You see this pre-treatment PET-MR images showing the pancreatic neck mass, which is enhancing and is encasing the SMV vessels here. And then this is the post-radiation image, again showing the region getting smaller, but still shows some subtle enhancement. So concerning if this is viable tumor or not. And then you can see that PET-MR helped that the lesion not only getting smaller, but less avid. So this was compatible with the responding disease. And then there was also decrease in that amorphous soft tissue at the SM vessels with improved uptake. The other thing which was noted was, look at this uptake in the right diaphragmatic growth on the baseline PET-MR. This would have been easily overlooked on the MR images, but on the PET-MR, you were able to identify that, and then that's also getting better. Case number 7, again, an Axumin F18 fluciclovine, rising PSA after multiple salvage treatments. And here you see recurrence along the peripheral margin of the ablation zone, where your contrast enhanced images also show some enhancement. But as life is, it's not always rainbows and butterflies. So there are some challenges with the PET-MR. The main challenges are the logistics, finding competent techs who are certified in both PET and MR. Approval and billing in US is a big challenge because insurance companies, it's not very many centers in US offer that. So most of the insurance companies are not familiar with it and reject it frequently. Alliance with the radiology division colleagues is important because someone has to read the dedicated diagnostic MR as well. So they should agree to read the MR portion. Basic training in MR for pure NUCMED people. And this can be a source of anxiety, but as I said, once you have a good liaison with your radiology colleagues, it becomes very symbiotic relationship when you set up the practice for the PET-MR. And PACS needs to be adequately equipped to handle this significantly large size of the DICOM files which are generated per exam. And what are the challenges related to patient? The time required for the scanning is a little long, so patient compliance can be an issue. Artifacts specific to MR are sometimes encountered, most common being motion artifacts, signal truncation, or sometimes dental artifacts. And with that, I'll end my talk. Thank you very much. This is our PET-MR scanner at Emory, and this is Dr. Hardik Shah, who is the director of PET-MR.
Thank you, Dr. Saima. Now we move on to the next topic, FTG PET in fevers of unknown origin and paraneoplastic syndrome. Dr. Athar, please.
setting up the thing. And based on our UCLH experience, the quality, I can see how much things have improved and how clever sequences you are using, especially for the attenuation correction and all that. So yeah, I must appreciate things that moved very positive, very forward, very encouraging to see you. Thank you so much. That's what I was looking for, really. Thank you. Right, less boring. So I put some animation and things because the first time I presented it, I saw somebody yawning on row number 3. By the time I reached slide number 27, row number 5 person was yawning. By the time I reached slide 30, the last person was yawning. I felt sorry, so I have to keep you awake. Sorry. So, okay, guys, so just let's be honest. You can yawn if you want to. I don't mind, but it's just that you have to post dinner. This is what happens. Okay, right here. Okay, let's get back to the topic. Right. Just to this small hand, it hasn't come this way. I want the first 3 slides. If you can have 20% more concentration than normal, that will actually help. If I be more sensitive and specific. So this is again these 2 terms are again from our evidence-based indication for PET-CT published by the Royal College of Radiologists. As a nuclear medicine physician, please be clear about 3 different terms: paraneoplastic syndrome, cancer of unknown origin, and pyrexia of unknown origin. Okay, so because we mix things up and sometimes it can look a bit odd because the MDTs are designed this way. Paraneoplastic is when you want to find one cancer. Simple. Okay, I have deliberately kept the handwriting small so that you listen to me and don't look at the screen. Okay. Carcinoma of unknown origin, there is cancer everywhere. Easy, you remember that? Okay. This one is a fever of unknown origin. Patient has temperature. What's the cause? So don't try to mix up the things, but the symptoms will overlap, right? The first one, the carcinoma of unknown origin, paraneoplastic. You're only looking for one enemy. But in other 2, there will be several. Okay, remember that? Okay, you're nodding head. That's better than people yawning from a previous experience. Getting there. Smiles is even better. Look at these 3 images. Fever of unknown origin. Okay. If you know the diagnosis, tell me. Anybody want to say anything? Okay, I'll give a hint. This is the second thing you will remember from this slide forever. Look at the ears of the patient. I've given you a hint. Okay, I'll come to it at the end. That's another trick to keep people awake. Right. This is the third thing which you will remember forever. I assure you, even I wake you up at 2 o'clock in the morning, and that's good disc, bad news, bad disc, good news. I'm not that intelligent that I come out with it. This is a sentence from radiographics paper. It was so nice that when I read it as for my radiology residency, that's the only sentence I remember from that paper. So it must be good. And why this is important? Because at MDTs, when you're pushed to the corner and you see lesions in the vertebra and the disc and the vertebra and the disc, and you're pushed to the corner, it's cancer, it's infection. It's cancer or it's infection. If the disc is bad, infection. If the disc is good, cancer. As I said about the Eric Segal novel with the lecture, there are only 26 facts. The rest is your guesswork. You'll be correct 65% of the time. Rest of the time, you'll still be wrong. So don't try to be a hero in front of a clinician. You still use your common sense, blood parameters, history, and everything. Okay. So these were the 3 good facts about the presentation and stuff. Right. Okay. Now, how you can combine different modalities to answer complicated question. Edward McIntosh is a neurosurgeon at Royal London, St. Bart's Hospital. He does very complicated cases. He asked me and he said, look, I'm operating on glioblastomas and things, and I don't know. These patients get temperatures. I don't know whether I'm leaving tumor there. There is infection coming up, or whether there is a viable tumor there. I need answer about inflammation, infection, and tumor. Can you help me? It's because I'm doing MRs and I'm not getting, like, the false positives are happening in complicated cases. Neuro is flooded with that. I said, okay, let's take it step by step. Step 1, with its white cell scan, with a SPECT CT. Okay, that was number 1. Number 2, we did the choline PET CT. Choline is increased cell membrane turnover, and it picks up inflammation and tumors there. That gives you a hint that there is a gradient which comes up with the choline. The tumors are higher majority if it's aggressive type, and inflammation comes less. And you see the color of the circles there? There's a bright spot at the front, and there is a circle-like spot at the back. Once we did that, and I asked him, let's do the MRI. And then do triple fusion. Let's combine all the three modalities together and put on top of each other so that you know. This was infection because it was positive on white cell scan. This was inflammation. And the MR, this is all residual tissue there. And I tell you, the slide you have seen before, she will have many beautiful surprises than this, what I have actually shown you. All the time mess I'm trying to give you is, sometimes PET does not give you the answer. You have to go down to the basics if you have the facilities available. This was the first PET MR, 2011 or 2012, Miami or Texas, which was when it was launched. That was like a first time Siemens were displaying that we now have a PET MR, and this was the model. I keep this picture because it's part of a good memory, because I know the journey of nuclear medicine will change, as you have already heard that how fascinating things have moved on to, right? So I have an animation slide over here. Guys, there's a bit of a sound there, and I want to emphasize that the breathing sequences, the artifacts caused by the movement of the diaphragm, the cardiac, the graveyard of PET CT is this mid part, right? We miss maximum lesions over there. Let's have. The technology is becoming very, very good. It's becoming faster. It's becoming more sensitive. Nuclear medicine is not grainy anymore. It is going to pick up small, tiny foci of increased metabolic activity, which are pathological and significant infection. So this is a spectrum of things which this carcinoma of unknown origin, pyrexia, paraneoplastic covers. Quite a broad topic to cover. Okay. I have one more animation to show, but I'll keep it for waking up session. 13 minutes to 17 minutes is my record based on the past experiences. So FDG, the most commonly used tracer, is used because tumors, infection, there is increased glucose consumption, and we attach radioisotope and we make it shine. Tumors with high SUVs, they show aggressive pattern. And if it's an inflammatory tissue, that shows reduction in SUV. Okay, you already saw a case in the PET-MR presentation that there was a lesion related to the diaphragm with something which slowed down and stuff. Okay, so that was a good example. Advantage, it tells you metabolic activity at cellular level. And I want you to tell you one sentence. If somebody asks you how accurate is your nuclear medicine, the cameras are 0.5, 0.3 to 0.7 centimeter accurate, what the latest generation are. But the tracer we use is accurate up to picomolar level concentration. I don't know how many 10 raised to power minus 6, 7, 8, 9, 10 are there. So the radiopharmacy is ahead of the game. Radiopharmacy is here telling you, guys, we can tell you information about the cell, sort out your cameras. We are head on with you guys, okay? In fact, ahead of it. Professor Jamshed Bomanji, who's my supervisor for the PhD, he had one very beautiful slide. At a national level, he was giving the talk. And I was surprised that the slide said, radiopharmacy is the king of nuclear medicine. And I was like, look, come on, radiologist, nuclear medicine physician, are we not kings, or where are we and stuff? So this is what FDG actually does when it enters the body. There it goes, see the orange color, the tracer going in. Okay, those of you who are not that familiar, the radioactive particle attached, and it goes in. That's circulating in the circulation. And as it's going in, it's making everything radioactive. Everything has become radioactive, and that's the cancer cell. Example, a lung tumor. What will happen? This thing which is floating in there, this is the structure of the glucose, that's going to go inside because of the GLUT receptors. It goes in there, and there's going to be a dissociation of the particle. There it goes. That's going to hit another particle. And what is this? Is annihilation, that the particles, they move in opposite direction. Once that happens, then the cameras, they pick up the pictures. Okay, now I tell you, our current generation cameras are giving us information only 1 to 2% of the radioactivity. Imagine once the total body scanners would be there. So all PET CT, what you're showing is only just this much. Most of the images which I'm showing is from my own paper from the clinical infectious diseases. There are 1 or 2 from other which I have referenced. So if I've forgotten to reference, I apologize beforehand. Sarcoidosis. The most common one which comes up in infectious diseases MDT and hematology MDT and name it, the musculoskeletal guys, that how much disease actually impresses. Histopathology becomes the gold standard at times. Sometimes they also struggle because of the overlap. I put this case in my paper because it had everything. Cardiac sarcoidosis, liver lesions, spleen lesions. The bone marrow was also abnormal. So it's multisystemic sarcoidosis. Clinical message here. Sarcoidosis imaging is different. Cardiac sarcoidosis imaging is different. Don't protocol both the same way. You will get deceived. Why I'm saying that? First case, St. Bart's Hospital, Cardiac Oncology Center, first cardiac sarcoid happening. They used to go to the UCLH, and I was really fighting, no, they should not go to UCLH. They should come to us. So the whole cardiology directors, everybody is saying the first case is going to happen. The heart light was lighting up, and they say, wow, this is cardiac sarcoidosis, beautiful scan. And I was just holding my head, what the hell, what has actually happened? You put the patient on carbohydrate restricted diet. And I asked my tech, call the ward. What did they give to the patient? And they said patient had pasta and rice. False first scan, false positive. Source of total embarrassment. Like, you know, when you start like this and you hit, there's no medal anymore. So don't go to the cardiac, give it to some other guy and you handle. So we have another colleague who looks after the cases, right? So just why I've told you this thing. Diet will kill your PET CT scan if you don't concentrate on this one. Carbohydrate restricted diet, prolonged fasting, whatever maneuvers you want to do. Some centers also give heparin. We are using heparin. It's a cardiology center. So this is one message from the total body PET image which I have seen. Sarcoid-like reaction, you see it in lymph nodes which are being treated and they mimic. So this is another entity. PET CT is beautiful because it tells you the stages. The disease goes all over. It starts in the lymph nodes, goes to the lungs, involves further lymph nodes outside the chest, diffuse lung, and the bone involvement. Now, if I show you this case, it becomes difficult to differentiate. Now, the serum ACE levels can be done, EBUS can be done if available, biopsy, these are all the maneuvers. But the challenge what the clinician face is that sarcoid patients get over-investigated. They get over-biopsied. So they look for clues from us to tell us what is actually happening. A bit of a 3D fancy reconstruction. This is an image from Professor Zumla's paper in Lancet showing TB with pleural involvement. And once he saw a processed image, he said, I wish I knew about that the PET can actually, a processed image can show activity like this. I was saying that we have been doing PET for so long. He said, the cosmetics are very important for us. You see, on the day of the wedding, you get ready. Why don't you understand that? Yeah. So you have to look beautiful as well. You have to look smart. And this is the problem. You don't like those hot spots only and stuff. So, okay. So this is another case of patient recurrent fever, had only tracheobronchitis. COVID, I think we started seeing a lot of it when we were doing imaging for cancer cases. For obvious reasons, all of you know that upper respiratory tract got involved and the distal respiratory tract afterwards, okay? I'll move on because the rest of them are pretty boring slides. Right, osteomyelitis. So this is FDG PET CT of someone which had a bone defect. There is increased metabolic activity, which is actually trapping up. It complements the role of MRI because you can actually tell if there is a metabolic activity in the joint above or below, and you can actually tell whether there are septic emboli. So if you are reporting FDG PET CT for osteomyelitis, You should know the orthopedic surgeon knows there is infection there. MR colleagues have given him plenty of information. Tell them there is no other source elsewhere. Your PET report is not complete if you haven't given information about other joint involvement and septic emboli. Okay, right. So this was that discitis case, which I showed. Most of the people are nodding head. They are still awake because I showed it at the time when majority of you were awake. A case of this TB where psoas abscess tracking along the iliac fossa. Right. Cardiovascular system. So infective endocarditis is a very common indication which we are getting in our cardiac center. And you can show them that the cardiac valves, they get increased uptake. There is good suppression of physiological myocardial uptake and inflammatory node, which was in the prevertebral area. So vasculitis, you can tell them about the pattern, about the size of the vessels involved. The least information required is large, medium, or proximal part of the small. I don't think that the current generation scanners, you can go above the submandibular or parotid level unless it's really, really. So be careful when using the word small vessel vasculitis, by the way. You maybe question how you detect your eyes are that of a tiger or something. So if your scanner is not picking up. Right. So there are two patterns, linear and focal. I showed you the image. The whole vessels were lighting up and you can tell them what is actually happening. So there are still some centers which techniques like gallium citrate and leukocyte. Don't underestimate those just because you have PET. I showed you the first case. The reason I show you the first case, by this time, we lose the message that PET is everything. No, general nuclear medicine has got a big impact. It's very, very strong. Everything can't go to the PET CT for resources region. This is a patient who has small lymph nodes bilaterally. This is HIV positive. This is a classical pattern we see in the HIV positive retroviral cases. It has, what should I say, a very bad impact psychologically when somebody gets labeled. So you see reactive nodes. I don't think PET can be used to say this is HIV. In HIV, you see this. You got the sentence right? So don't try to label it. But this is, I looked at about 32, 34 HIV cases, and I was saying, what is wrong with these axilla and the inguinal nodes? There are tiny, tiny nodes which are actually shining, lighting up. And I asked Prof. Omanji, should we be writing down that retroviral should be excluded? He said, no way. Don't do that. Because when the family, they receive letters, it has drastic psychological consequences and stuff, right? Okay, we have covered this. There are some alternative agents which are actually coming up. I wouldn't go in the boring details of the mechanism of action impact, but nuclear medicine community, radiopharmacy is working over those agents. There are well-established indications for all of these. There is debate about whether fungal infection, asbestosis, pericarditis, and central nervous infection can be used because there are other radiological modalities which have a very important role. So PET CT is a fantastic modality. It gives you information about the whole body, precise anatomical localization, metabolic activity, how metabolically active the lesion is, and there is good definition of the lesion. So we come back to that. You remember? All of you looked at the ears of this. Though you forgot about the whole body, and all of you were looking at the ears of this one because I gave a clue. Does somebody want to have a go at it? What's the diagnosis? Because now all of you will remember the ears for these cases. Okay. Anybody? These are three cases of vasculitis. Everybody agrees on that. Now your rheumatologist who trusts you and who says you're a very good radiologist and a very good nuclear medicine physician, tell me more. Which one is that? Polyarthritis nodosa and relapsing polychondritis because of the costal cartilages and the cartilages in the ears make the cartilages shine. And even in most complex cases, I don't commit to Takayasu's and the giant cell. This was the giant cell, this was the Takayasu's. But I think 80% have always been wrong. So I have lifted my hand up and I say, show me the ears. That's the only one which is going to be correct. Rest all is your guesswork, right? I find it very, very challenging and I stick to vasculitis. Sometimes one should openly admit my lack of knowledge rather than people 100% saying that this is what you would be. Right. One or two good quick cases, which I will show you. So, how much time do I have, Hacha? Or have I crossed? Stop?
No, you can continue, that's fine.
Do I have?
Yeah, 5 minutes.
You've got 5 minutes, okay. So this was a case of lymphoma. You can see nodal disease, you can see splenic metabolic activity and all. Why I'm showing you such an easy case if you are a routine reporter in an oncology center or you're a technologist, you do that. The problem was here. Okay, and I show you for more zoomed images and stuff. This area over here, okay? As these patients are immunocompromised, they develop abscesses. The message which I want to give you is be careful when you are reporting something as excreted activity and contamination. Okay, it was a full-blown abscess sitting over there. There it is, tracking in the skin exactly where I'm not showing an easy case without a clinical message there. So, and what I did, that this was actually tracking all the way. I could have adjusted the intensity more, but it was tracking along all the perineum. And I adjusted the colors of it, again, cosmetics. And I want you to focus on this tiny blue dot over there, because it was not just only that area between the legs, there were also skin abscesses which were coming up. And the urologist then examined and found, look, there is, it was almost making a fistula. It was that bad. Right, this case, why I'm showing that again. Right, have a look at the brain of both of these cases. This was a patient with advanced lymphoma. What happens that when there is extensive extracerebral disease, the brain metabolic activity goes down. That's called Steele phenomena. And when you treat well, not only the tumor, but this activity comes back. And that's reversal of the Steele phenomena, that whatever glucose was being stolen is back to its house. Okay, so message here: dementia cases, Alzheimer's cases, when you are seeing that there is diffuse reduction of metabolic activity, be very, very careful. It's not just Alzheimer's. Are there weight loss symptoms to pick up? This is the trap here, because you will pick up, your physics colleagues will process the Z scores or fascinating things, whatever you have, and you will label the patient as Alzheimer's and the dementia when there is a full-blown house outside the body with cancer doing all the tricks and stuff. This was a renal case. I think we almost missed it because we thought excreted activity, but this one was too obvious. It was picked up as a second read. It was one of the misses, because if you look at the MIP image, we were all focusing on telling of the technologist why the extravasation and all that has happened and all that, and we forgot our own homework, missed out the renal lesion. Sometimes it's good to share embarrassing moments in gatherings like this. We just feel lighter. You know, people start opening up and say, American Society of Neuroradiology Intervention have a session like this. The big gurus, they close the door, they bring the cases, and they discuss where I've messed around, basically. And they say where the guide bars have gone, some ERCP happening, and that's gone into the liver, into a thing, and they discuss where they have put the drain in the heart. It's good to discuss. This will be the only chilling session to talk about it. Outside is total embarrassment, yeah? Okay, I'll finish off over here. I hope you're all awake. Thank you very much.
Thank you so much for such an enlightening talk. Last, Dr. Saima to talk about when to use 18 FS PET-CT in breast cancer patients. Thank you.
Thank you, Dr. Hajra. Thank you, Dr. Athar. Very excellent presentation, something that we encounter very frequently in our daily clinical practice. All right, so my topic is FESPET, when to use it in breast cancer patients. So I was thinking how to present this, and most of in Pakistan, we are not using it. So I said, let's start with a curbside consult, something we as nuclear physician or images encounter very frequently with our med-onc colleagues. So my med-onc friend called me from her clinic about a new patient. Patient had CT and MR showing numerous lytic lesions, underwent 2 biopsies, the outside pathology reports suggest poorly differentiated breast cancer, breast origin, insufficient tissue for immunohistochemistry, unknown ER status. Her question is, should I get a FAST PET to determine ER status? My response was, well, I need some more information. Does the patient have known breast cancer? She said, nope, she is set up for a breast MR here. I said, great. If they find something to biopsy, that will help. She then goes on and says, let's say this is unrevealing. They don't find anything. What then? I was like, start with an FDG PET. It's simpler, cheaper. You really should have one before doing a FES also. Will also give you a better target to biopsy. Then if there is a question about ER status and best management, FES is always there to enable a whole body biopsy to address potential clonal heterogeneity and also prognosis to endocrine therapy. So the goal of my presentation is to understand the scientific basis of my reply to my oncology colleague. So a little introduction, we all know breast cancer is one of the most commonly diagnosed cancers worldwide. In US is the second leading cancer after lung and is the leading cause of cancer in African-American women. So about the immunohistochemical staining and receptor status, we know the receptor profile of breast cancer allows for prediction of outcome and direction of patient treatment. NCCN recommends receptor status testing. In current practice, immunohistochemical staining is the reference standard for assessment of receptor profiles. So it's the ER, PR, and the ERB2, previously known as the HER2, are routinely quantified. A breast cancer is considered hormone HR positive, it is ER or PR positive. So HR status has an impact on breast cancer management. Approximately 80% of all newly diagnosed breast cancers are HR positive. And patients with HR positive, that's good news because those patients have better overall prognosis. If we look at the HR positive localized breast cancer, 5-year survival is 99 to 100%, and it's about 91 to 97% with HR negative disease. In metastatic HR breast cancer setting, 5-year survival is 32 to 46% compared to the decimal 12 to 40% in patients with HR negative metastasis. So it looks very promising, but at the assessment of tissue ER expression is not that easy. It has its limitation. There are several inherent limitations. Obtaining tissue is often challenging and depending on the anatomic site. And the most notorious ones are the osseous metastasis. And it's difficult to sample. And sometimes because the way the samples are treated with the cortical samples, they sometimes lose the ER positivity because of the immunohistochemical staining process. And then disease heterogeneity is another big giant. Then, the invasive nature of biopsy limits that you can't biopsy each and every lesion that you are concerned about. And then sampling error and lab differences, of course, add another layer of challenge and complexity. So there has been a need to evaluate breast ER expression, which could be complementary to tissue assay. So some kind of a non-invasive agent for imaging ER expression. And then this is how FESPET comes into the arena. It was FDA approved in US in 2020 as an adjunct to biopsy in patients with recurrent or metastatic breast cancer. And what actually is FESPET? It's a radio-labeled form of estradiol, and it allows whole body non-invasive evaluation of ER receptor. And Europeans have been doing it for more than a decade now. This was approved in France in 2016. And the indication was ER positive breast cancer who present with recurrence or metastasis unfavorable to biopsy. In US, it is marketed under the trade name of Cerianna by GE Healthcare. How good is FESPET? Whenever a newer agent comes in and it's marketed, there's always some data and studies done about the sensitivity and specificity. So specificity of FESPET is greater than 90%, while sensitivity ranges around 70 to 90%. There have been multiple large prospective multi-center studies. The most notable one is by Gill et al. They found excellent positive negative predictive value of FESPET compared to ER protein in biopsied metastasis. In 2023, SNMMI, they published the appropriate use criteria for FAST PET imaging. And they scaled it from 1 to 9. Scores of 7 to 9 were the appropriate use criteria for getting a FAST PET. Score of 4 to 6 is kind of that intermediate, moderate, appropriate use criteria. May be appropriate, more evidence is needed. If the score comes around 1 to 3, those are really appropriate criteria to get a FAST PET. So this is a summary of different appropriate use criteria. As you can see, they have divided into different scenarios based on the diagnosis, staging, biopsy, or selection of therapy. Among different scenarios, what are the ones which have the most greatest yield or the highest appropriate use criteria? It's scenario number 9 and 10, after progression of metastatic disease and considering second-line endocrine therapy. You can see the score is 8. And also at initial diagnosis of metastatic disease for considering endocrine therapy. That's also a very appropriate use criteria of FAST PET. The other important is detecting ER status when other imaging tests are equivocal. That's an appropriate criteria. So to sum it up, clinical scenario 8, we're assessing ER status in lesions that are difficult to biopsy. Scenario 9, after progression of metastatic disease for considering second-line endocrine therapy, or scenario 10, at initial diagnosis of metastatic disease for considering endocrine therapy. And measuring response to therapy is not appropriate. There are a lot of trials and studies going on whether FAST PET should be used for measuring response to therapy. But that's not a legit or valid indication at the moment. In 2024, SNMMI along with ENM published the procedure guidelines for FAST PET imaging. And what are those? Patient preparation is pretty straightforward with FAST. For FAST PET, hydration is required, no specific diet, fasting, or lab testing is required, except for pregnancy test in childbearing females. Lactation per the Syriana package is that to avoid breastfeeding for 4 hours after administration of FAST PET. What is highly recommended is image the patient before they start the ER antagonist therapy, defined as SERMs or SERD, which is estrogen receptor modulators such as tamoxifen, and SERD, which is fulvestrant. And after stopping ER antagonist, there's a certain washout period that you have to be mindful. That is why doing the study before they started is very helpful, because you have to wait for 8 weeks for tamoxifen and 28 weeks for fulvestrant. And but some of the other treatments that patients are getting, like aromatase inhibitors, these agents decrease peripheral and local estrogen production, but do not block ER. So you don't have to stop the patients who are on aromatase inhibitors. So same holds true for kinase inhibitors, CDK4/6 inhibitors, because again, these agents do not interact with the ER. So patients can get FAST PET while they are on these agents. The recommended dose is 6 millicurie, acceptable range 3 to 6. Void immediately before to reduce activity in the bladder. And imaging is optimally performed 60 to 80 minutes after injection, arms by the side, skull base to mid thighs. So this is the same image windowed at different window settings, and that's showing the normal biodistribution. You can see it's metabolized through the liver, so you see a lot of liver biliary, duct uptake, small bowel uptake, excreted through the bladder. Then structures which have high ER expression, such as uterus, lights up on the scan. So familiarity with the biodistribution is very important. Again, the same thing, familiarization with the normal biodistribution. Confirmation of uterine uptake is kind of an internal control, demonstrating adequate FAST tissue targeting and uptake. And FAST is specific for functional ER expression. Sites of uptake outside the normal is abnormal. Unlike FDG, FAST is usually not taken up by inflammatory degenerative changes, except for radiation pneumonitis, atelectasis in the lungs, you may see some uptake. So the interpretation criteria, usually the cutoff SUE max is 1.5, and qualitatively you can also see uptake higher than local and blood pool, and which is outside the normal biodistribution that is interpreted as FAST positive disease. And usually the one thing that you have to be mindful of that in a FAST PET, a positive disease won't light up like a Christmas tree or a light bulb. The uptake, as you can see, the SUV cutoff is 1.5. So You have to set your window settings appropriately so you don't miss FES positive things. Again, different window settings showing, especially for liver lesions, that's a limitation because there's too much liver uptake that can obscure underlying FES positive lesions in the liver. So looking at different appropriate use criteria, what are the different roles that FES-PET can play? One of the most important roles, as you can see, based on the appropriate use criteria, is that FES-PET comes into play as a problem-solving tool, where there is a question, clinical question or dilemma that needs to be answered. And this was a very nice retrospective study by Bohr et al. What they did is they enrolled patients suspected or known ER positive metastatic breast cancer, where there was some clinical dilemma not answered by standard imaging. And the dilemma was solved in 87 of 100 scans, so 87%. In 81 of these 87 scans, a treatment decision was made based directly on those FES-PET scans. What else? What other role we can assign for FES-PET? Can it be a predictive biomarker, a predictive imaging biomarker in breast cancer patients who are ER positive? There is a role, and FES has a potentially superior predictive biomarker for determining whether the patients would benefit from endocrine therapies or not. So in patients with ER positive metastatic breast cancer, by biopsy, with lack of response. So that's a very important information that we get. And to date, at least 17 prospective trials have demonstrated FES-PET as a robust predictive biomarker. This is a very good example of a responder versus non-responder. You can see the FDG PET in a responder, multiple disease sites also lighting up on the FES pre-treatment and the post-treatment, everything got better. So it's a responder versus this one, lot of disease sites on FDG, very minimal uptake on the FES, and this patient continued to progress. If we look at the NCCN guidelines till to the last time I checked, FDG is recommended in advanced breast cancer in stage 3. They do recommend in special circumstances to do it in stage 2 as well, especially if the standard of care imaging like CT bone scan are equivocal or there are some indeterminate findings, but they don't endorse FES-PET as the baseline imaging. Based on that, Gary Olener, who has published a lot on breast imaging, they did a this is very nice retrospective study. The question was, does FES-PET perform as well as standard of care imaging for staging locally advanced breast cancer or evaluating suspected recurrence? So this was a single center phase 2 study. They divided the patients into 2 cohorts, one in locally advanced breast cancer, the others was a suspected recurrence cohort. And what they found was there was no statistically significant difference between standard of care and experimental FES-PET for detection of pathologically proven distant metastases. So what does it mean? FES-PET could be considered for staging or detection of recurrence in patients with ER-positive breast cancer, most likely, but then we have to take this with a grain of salt. There was a very nice commentary that was published by Brian after this study was, Olener's study was published. So Olener pointed out the utility of FES-PET in staging of ER-positive breast cancer. But the thing is that Olener, you know, in their study, it was powered to identify 20% improvement in the detection for FES-PET compared to standard of care, which also includes FDG as standard of care. But what they found in the study was that there was no statistical difference. 50% of lesions were either detected by standard of care versus PET. So what does it mean? This provides some hints whether FES and FDG might be complementary. Am I making sense here? So metastatic breast cancer has both spatial and temporal heterogeneity, right? We know that with variable FDG and FES-PET. So I think the best of the 2 worlds would be to combine the FDG and FES-PET because these 2 diagnostic tracers demonstrate different and complementary information, and that would improve prognosis and optimize treatment decisions in these patients. Because if you combine FDG and FES-PET in these patients, Any lesions which do not have FAS uptake indicate loss of functional ER expression. That means that they may be ER positive by pathology or by IHC, but they don't have the functional ER expression. And that's important in choosing treatment, like patients who don't show a FAS uptake, the oncologists decide of doing chemotherapy rather than endocrine therapy in those patients. Some few clinical scenarios. Patient number 1, 68-year-old with invasive lobular cancer, axillary nodal metastasis, questionable sternal lesion on MR, and CT and bone scans were negative, but they showed a suspicious prevascular node in the mediastinum. Is this patient the indication for getting a FAS PET? Does it fall under the appropriate use criteria? It does. So FAS PET was ordered. This is the primary lesion lighting up. You can see the axillary nodes lighting up. The prevascular node doesn't have much uptake, so this was presumed as negative for FAS PET for ER expression. And then the sternal lesion was lighting up. And you can notice how the uptake isn't super high, but it was higher than SU at 1.5, so it was taken as positive. But you can see there were multiple other lesions which were lighting on FAS PET. So this was upstaged, and biopsy also confirmed stage 4 disease. Patient number 2, 76-year-old female, PR positive or P negative invasive lobular cancer, indeterminate right axillary and cervical node seen on FDG PET. Patient had a FAS PET. Does that fulfill the appropriate use criteria? It does. It's routine staging of extra axillary, nodal, and distant metastases, and then staging in invasive lobular or low-grade cancers. So patient underwent FAS PET. You can see nodes lighting up in the right neck, right axilla. They were biopsied. This was cancer. Patient was upstaged to stage 4. Patient number 3, 55-year-old, HR positive, right breast cancer with bone and lung metastases, underwent radiation therapy. Patient is currently on letrozole, which is an aromatase inhibitor. FAS was decided because they were worried that the patient is getting disease progression. They wanted to decide second-line endocrine therapy. Does it fulfill the appropriate use criteria? It does, selection of therapy. And this is how the images look like. This was done at Emory, and you can see multiple osseous lesions lighting up on the FAS PET. This helped in deciding next line of therapy and consider fulvestrant along with CDK4/6 inhibitors. Patient number 4, 66-year-old female, ER positive invasive lobular cancer with ER positive left supraclavicular nodal metastases, and there was presumed ER positive osseous metastasis. That's again appropriate use criteria to get a FAS PET. And the left supraclavicular nodes are lighting up. They already knew about it. And there were multiple osseous lesions which were lighting up, again, changed patient management. This was a very nice case, 41-year-old ankylosing spondylitis, diagnosed with ER positive breast cancer, complained of neck and back pain. Conventional bone scan was performed, which showed non-specific heterogeneous uptake in the spine and pelvis. Does that fall under appropriate use criteria? It does. Detecting ER status when other lesions are equivocal. So this did fall under the appropriate use criteria. Patient underwent FAS PET showing multiple lesions, especially in the spine as well. And on the basis of these findings, diagnosis was settled for metastatic breast cancer. And patient was also given radiation therapy to the cervical spine. This is an image from one of the study that Gary O'Leonard did for FAS PET. This was a 50-year-old suspected recurrence invasive lobular. You can see this uptake in the lungs and bilateral lung uptake. And this is the breast cancer lighting up in the left breast. Patient also got FAS PET. And the beauty here is that on the FGG, you see all these lung lesions lighting up. But when they did the FDG, the FAS PET, the lung up, there's no uptake in this. So this was deemed as inflammatory, but they noticed this uptake in the stomach, the gastric uptake, and then unsuspected osseous lesions. So that changed the patient's management. So showing all these cases, it looks like it's the problem-solving tool. It is, but there are limitations to FAS PET. There could be a lot of false positive, especially in ER positive non-breast entities such as fibroids. Less commonly, meningiomas also light up on PET. Radiation pneumonitis, as I mentioned, or sometime atelectatic lungs may have some uptake. False negative is especially small lesions with low ER expression. Those adjacent to within high areas of uptake, such as adjacent to the liver. Liver lesions may be missed out because of the high physiologic uptake. Peritoneal metastasis close to the bowel and bowel metastasis may be missed. So in summary, when to use it in breast cancer patients? As an adjunct to biopsy, FES can be used as selecting a biopsy target, assess the burden of ER positive disease, clarifying FDG AVID findings, identify spatial and temporal ER heterogeneity. What are the possible future applications predicting response to systemic therapy, demonstrating effective ER blockade by ER antagonist, initial staging of ER positive breast cancer, and clinical use in other patient population like endometrial cancers like that. Thank you very much. This is Nuclear Medicine Division. We had a party at my home. This is David Schuster, who is our section chief. Thank you.
Thank you so much, both of you. Thank you to our both guests for your wonderful and enlightening talks and your sharing your experiences about areas of nuclear medicine most of us are not as familiar with. Unfortunately, a little bit of short of time, might not be able to have a panel discussion as such. But if we have one or two questions, we can maybe just do them now. And then if there's anything left, we can do it after the session. I think you're both here this afternoon, isn't it?
Wanted to convey, we have a message from Dr. Humayun Bashir. He says, thank you both for joining us. And he's very, as are we, extremely appreciative of the excellent talks that you gave. I think this was one of the best SKM sessions for nuclear medicine that we've had. And so questions, please. Anyone? So I think the plenary session starts in a few minutes downstairs. If anyone has questions, we can, address them with the speakers later on.
Yeah, I think so. I think Dr. Ahmed had a few written down, but maybe we can do that, discuss them after that. Yeah.
Thank you.
Thank you
Thank
so
you.
much. Thank you again.